Doctor, I want to, Zafar, is it okay?
Okay. Okay. Yeah, we are live on YouTube. Can you check?
Yeah, Namita, can you please share your screen, please, so that I can have a look at the Facebook because it is also live on the Facebook.
Yeah, ma'am. Yeah, we are live on YouTube.
Do you want me to share the screen or okay, she's doing it.
Good evening, Surya sir. Good evening,
evening.
Dr. Marian.
Good evening, sir.
Hi, Dr. Surya. Hi, good evening.
Hello.
Hi,
Yeah, good to see you.
how are you?
All good.
Is it live streaming started?
I think it's about to start at 8.
Okay, fine. Yeah, then it's fine. Always nice to meet you in the thyroid webinar.
Anurit, I think Anurit can share the screen. Good evening, everyone. So, are we live? Yes, it's 8. Yeah. Anurit, you can start.
So, good evening, everyone, and welcome to this webinar on thyroid eye disease. And this is a part of the Thyroid Eye Disease Awareness Week, which is from 10th to 16th. And the reason for this webinar and for this activity during Thyroid Awareness Week uh, is because thyroid is a great burden in our country, around 42 million as per some of the data. And out of these 42 million, ranging on various geographical distributions, 28 to 47% can have thyroid eye disease, which itself can vary from a simple dry eye to loss of total vision. So, through this webinar, we have three different speakers and three different topics that we'll be covering. And we have experts in thyroidology, I might say, experts who are dealing with thyroid eye disease in good numbers and are leading international speakers. And the first speaker for the day is Dr. Surya Snatarath. He's the Director of Operations and Home Care Services at the LVPI Institute Network. And he's also head of the Ophthalmic Plastic Surgery Department at the MTC campus in Bhubaneswar. Sir is the education in charge and the executive board of the International Thyroid Eye Disease Society. And he has been the project coordinator of the Tribal Odisha Eye Disease Study, which is funded by the Ministry of Tribal Affairs, New Delhi. Dr. Rath underwent his long-term fellowship at LVPI Hyderabad, and he's also the editor of a textbook which is widely read, which is Thyroid Surgery in Thyroid Eye Disease, a Conceptual Approach. And he has multiple publications in peer-reviewed journals and 5 book chapters. So I welcome you, sir. And next speaker for the day is Dr. Marian Polly, who's a senior consultant and HOD at Giridhara Institute at Kochi, Kerala. She underwent a clinical fellowship program in orbit oculoplasty trauma at Shankar Netralaya, Chennai, followed by an ICO short-term fellowship in ocular oncology from Wilsey Hospital, USA. She is the recipient of Jayaben Chamanlal Shah Gold Medal at Shankar Netralaya, Chennai, Dr. Gangadhar Sundar Award for Young Oculoplastic Surgeon in the OPI Conference 2012. She is also the recipient of Dr. Noel Moniz Award for the best paper from Kerala Society of Ophthalmic Surgeons. So welcome, Dr. Marian. And Anurit, you can introduce Dr. Namita now.
Good evening, one and all. I would like to introduce Dr. Namita Kumari, who is currently working as a consultant in the Department of Oculoplasty and Oncology at Shroff's Charity Eye Hospital. She did her MBBS and MS from GNMCH Aligarh and did her fellowship in Oculoplasty and Oncology at Shroff's Charity Eye Hospital. She has 17 publications in peer-reviewed journal and has presented at various scientific presentations at national and international level. She has published book chapters on orbital retinoblastoma and visual and prosthetic rehabilitation. Her areas of interests are eyelid and orbital surgery, thyroid eye disease, socket reconstruction, and orbitofacial reconstruction. She has also worked as a reviewer for OPRS and Oman Journal of Ophthalmology. I would like to introduce the moderators for today, Dr. Obedur Rahman, who is a consultant in the Department of Oculoplasty and Oncology at Dr. Shroff's Charity Eye Hospital. He did his medical schooling from Maulana Azad Medical College, New Delhi, and Government Medical College, Chandigarh, where he bagged a gold medal. He did his fellowship in ophthalmic plastic and reconstructive surgery and oculofacial aesthetics from Sri Shankara Netralaya, Guwahati. And he has more than 50 academic publications in national and international journals. He also received International Travel Scheme Grant in 2022 by the Science and Engineering Research Board. He has multiple awards, Best Free Paper Award, Best Physical Poster, and Best Video Awards at AIOC 2025. His non-academic interests are he is an avid reader, a writer, and published author.
Thank you, Anurit. And now I'd like to introduce Anurit, who's a senior fellow at Dr. Shroff Charity Eye Hospital here. She's done her MBBS from AIMS Rishikesh and MS from Jipmer Pondicherry. And okay, we can continue the session now. And I would like to invite Dr. Namita first to present her talk to start the session.
My screen visible, Uvaid?
Yes,
Yeah, it's visible.
So coming to my talk today, good evening everyone and welcome to this interesting webinar. I'm looking forward also to talk of Dr. Surya and Dr. Marian. And thank you, Anurit, for the nice introduction. So today evening, I will talk about the thyroid eye disease, what's in Indian scenario. And briefly, I will cover the overview of the epidemiology, clinical features and management in Indian scenario. So coming to the epidemiology, the first thing comes in our mind is that what is the incidence and prevalence of the disease. In India lacks the population-based study. However, in the Caucasian population, they have done that population-based study, and that has reported the incidence of around 16 patients per lakh for female population because they have a female preponderance, and 3 male per lakh population. Coming to the Indian population, the prevalence of that Graves' ophthalmopathy is in the Graves' disease is around 28% population. And in Thyroid Eye Clinic, one study published in 1992 by Khurana et al. Has shown that 36% patients are euthyroid, and there's a slight preponderance in our Indian population, and that ratio is around 1.5:1. This is the one of the landmark study, I would say, especially for the clinical profile of thyroid eye disease in the Indian population, done at our center, and in of population in 106 patients, in which there was a slight female preponderance was noted, and euthyroid status was noted in around 20% population. And that has actually created a lots of idea that does the our thyroid eye disease patient the profile is differ from the Caucasian one. And on that, the Ayushi Agarwal also has commented in one study. They have compared our study with the Western population, and in their cohort of 150 patient, again in that cohort, what they found is that there is the female preponderance, but compared to the Western population, that is not much, because in their population the ratio is usually 3:4, and in our population it's a just slight female preponderance. Age, there's not much different in the age presentation, but we have actually 1 decade earlier the presentation of the disease. But however, what the most common thing is that in our population, the lot of the patients present as an inactive thyroid eye disease compared to the Western population, where the 60% population is actually present with that inactive disease. And in our population, around 70% population present with that inactive disease. And then come the next, the large cohort of 1,000 patients from the LEPI data, and that has again confirmed our findings that our population, even that in this study, they have a male preponderance, and that ratio that is the 0.89:1. Again, this study also said that the euthyroid is around 1/3 of the population presenting diagnosed as a thyroid eye disease has a euthyroid status. And this study also highlighted one of the thing that out of all the presenters, we have around 1/3 are like the silent presenter, especially during the active phase, that is around the 1 to 3 year during the disease course. This study also compared with the other South Asian studies done in the Singapore and Malaysian population, and what they found is that that is the our population is similar, has that gender profile and in the clinical disease condition. So there's also one interesting comparison that they have done very in a pilot study compared with the United States and the Indian population, where they have shown that the US cohort is having around hyperthyroidism association compared to only 52% in Indian population, and their activity score is around 4, and in our Indian population the activity score is around 1.65. So coming to the risk factor that we all know in the thyroid eye disease, especially the smoking, worsen the disease, and the diabetes status, and the thyroid dysfunction. However, there is a recent uh, study suggestive that obstructive sleep apnea is one factor, modifiable factor, that is also associated with the thyroid eye disease. However, what is the difference that what we found in the Western population, they have reported that obstructive sleep apnea is associated mainly with the severity of disease. And these are the only two studies that have been published. So what we did that we have assessed the risk of obstructive sleep apnea in thyroid eye disease patients with gender and age matched control population. And what we found is that the obstructive sleep apnea is mainly associated with the activity, not much with the severity. And that is probably because that obstructive sleep apnea and thyroid eye disease both share the common inflammatory markers. So coming to the clinical features, the most common clinical features are that proptosis is the most common sign and symptoms, with the lid retraction and the lid lag, as per our the Indian study. In our study, we have a very less cohort of the population having the exposure ketopathy or dysthyroid optic neuropathy. The most common sign and symptoms has been reported is the proptosis and the dry eye-like symptoms. Coming to the management part of the thyroid eye disease, that we all know that thyroid eye disease has a biphasic course of the disease. So if you want to treat the disease, you have to treat in the active phase so that you have a less fibrosis in the quiescent phase. Coming to the management part, what we follow is the mainly the latest UGOGO guidelines, and that according to this guideline in the mild thyroid eye disease, what is the important is that the local and conservative management. The selenium supplementation again is that depends on that the geographical availability of this. If that is a deficient in your population, in Indian population, what I feel that selenium supplementation is the not widely used. Again, in the patient in the mild thyroid eye disease, they present usually with the lead retraction. In the active phase, you can give the steroid injection, and in inactive phase, the surgery and Botox injection can be given. Surgery or filler can be done. For the moderate to severe thyroid eye disease, what UGOGO advocates is that 500 mg IVMP dose per weekly for the 6 week, and then you have to assess for the response. If there is a no response or deterioration, you can move to the second line treatment. So this is the patient that has received the of a moderate to severe thyroid eye disease. She has received 500 mg weekly IVMP for 6 weeks. Along with that, mycophenolate mofetil sodium per day for the 6 week, and she has shown a good response for the clinical resolution of signs and symptoms. Coming to the second line of treatment, that UGOGO said that you can shift that other shift like that you can give the IVMP at least start the second dose of gram. In one cycle you can give it the maximum 8 gram, but in the another cycle again you can start. The orbital radiotherapy also can be given. Teprotumab is something that is not available in the India. In India, the rituximab and tocilizumab are the other immunomodulators that are available, and that can be given into the IV doses and subcutaneous doses. So I think Dr. Surya will talk about that more about the tocilizumab role. Coming to the side-threatening thyroid ophthalmopathy, once you have that a patient of this thyroid optic neuropathy, with the patients having the vision loss, and also there is a fundus, uh, clinically you can see that there is a RAPD fundus, there is a disc edema, and also on the radiological imaging where you can see that there is a compressive optoneuropathy features. You should start immediately the patient on the IVMP 1 gram, maybe for the 3 consecutive days or alternate days. If it's respond to that, then the further can be continued for the IVMP. If there is a no response, patient should be taken for the urgent decompression surgery. So coming to this thyroid eye, I found this one interesting article for the thyroid eye disease preferred practice pattern in the India. And in India also, the most of the oculoplasty surgeon use the corticosteroid as a first preferred treatment of choice. However, for the second line of treatment, 50% use the immunomodulators. There are 3/4 quarters that people had responded that orbital radiotherapy is not they are using for considering the because of the efficacy and the safety in the patients. So Dr. Marian talk might enlighten us that the role of the orbital radiotherapy in such population. So what I feel that in India, we need to start the first the thyroid eye disease is in India to know the disease prevalence, and also some tiered proteomics study can be done to see that why our population is different. And also we can develop some thyroid eye disease patho model to understand the pathophysiology of our population, including the culture on the orbital fibroblast, and see, we can see the expression of the marker. Another very important that what we can do is that as we found that obstructive sleep apnea is one of the modifiable risk factor, can the treatment of obstructive sleep apnea lead to the like uh, better management of thyroid eye disease. Thank you.
Thank you, Dr. Amita. Wonderful presentation. And any comments from the panelists?
I think, Namita, that's a very, particularly the talk about the prevalence of the disease. More importantly, I think there was a time when, first of all, we always thought whether in India, the patient population that we see is actually following the Rundle's curve or not.
Yeah,
And this used to be a commonly discussed topic in international meetings too. But I think what has multiple studies showed is that we probably have a little difference in the way patients present. And there's a possibility that the A type, the appearance type, which we talk about, which necessarily may not have high CAS scores, are probably maybe from at least the studies tend to show are far more commonly seen, and that also goes to show that radiological parameters to look at disease of how much the muscles are involved may have a bigger role in Indian scenario.
Yes, sir. I think probably that our fellow Marnia will present and that we will cover that aspect, sir. Yes.
Good, yeah.
One thing that I want to put to the speakers or the panelists, that since the presentation of thyroid disease, the prevalence, and maybe the disease process also is very different in our population from the Western population, and the standard protocols of treatment that are formulated and followed are usually based on Western population and their studies. So is there also a need to study that if the management, particularly in our population, needs to be different from what is formulated in the formal guidelines?
Yes.
You can take that and probably, and then uh, anybody who feels may add actually, but I would probably start with saying that that is exactly the reason that we realized when we looked at a retrospective cohort of about 300 patients that the people who had diabetes mellitus were tended to not respond to the standard therapies, and the challenges that we faced here with the we don't have the infusion centers or management which can be done at a much more intensive level, and the patient is constantly under the let's say the guidance or the supervision of a physician all along when the treatment protocols are given. So our the margins for safety are a little different from others, and I think the patient cohorts are also different, essentially leading to our observation that in the group of patients who tend to have multiple risk factors, which we decided as two and more, which could be a combination of old age, diabetes, male, and diabetes, whatever, you tended to have a little different protocol. And that's what led us to thinking that probably surgery in the beginning, followed by immune modulation, is a better strategy to go for. And I think it's very much the need as the larger number of cohorts are described and reported to find out what works better in our population. That's definitely the need.
Yes, and also the risk factors. This obstructive sleep apnea, the ones I started, now I have incorporated actually the stop bank, the criteria that we used to screen this patient. I mean, even they lose the weight, also their sleep apnea symptoms improved. I have seen that the improvement in the thyroid eye disease, and there is actually we know that they have a share the common inflammatory mediators that in the patient, like the smoking also increase IL-6, OSA also, and in our population we have lot of OSA disease.
Yeah, I would absolutely agree. And just to add, Namita, when we were looking at sort of the same background of why should there be and how exactly are the different risk factors interrelated we were looking at that, we found that actually obesity has a big role to play. And knowing the close association between obstructive sleep apnea, obesity, and its in relationships, it is quite, it is, I think it's quite possible that both go together, and controlling one or many of them could have a huge impact on the overall disease.
Yes.
Absolutely agree. Yeah.
Yeah, and but sir, there's the one surprising element that I have seen, that I expected the hypothyroidism might be related with that OSA, but it did not come significant in our study. Probably maybe because we also have the subset of the thyroid eye disease patient who is euthyroid also. Maybe with large cohort, we might get also that correlation with the hypothyroidism, because that is associated with more with the obesity. Yeah.
Yeah.
We can move to the newest next speaker. Well,
Yeah, so I'd invite Dr. Surya now to share his screen,
yeah, I
and he'll
stopped
be
sharing.
talking on what's new in thyroid eye disease.
Okay. So I lost you for a while. So am I supposed to go next? Shall I
Yeah,
share?
yeah. Yes.
Just let me know if you can see my screen.
Yeah, it's visible now.
Good. All right. I think that was very helpful, Namita, because you touched upon several things that would make my work a little easier. And I have thought that I would probably talk about a few things which are new and which is also relevant to in our scenario. I'm not going to talk about teprotumumab, but something related and some results. This is my only financial disclosure. I'll quickly jump in by saying that we know, and most of the time we talk about progressive, active versus inactive. And I just wanted to highlight this point that we have our clinical activities and all that. We also come across in the Indian scenario very often situations like these when you have corneal breakdown, microbial infection, and all sorts of other, let's say, causes of inflammation confounding a clinical risk factor. I mean, what exactly is the activity score? And a simple thing that apart from what else you see, we probably have to rely upon which one. And in this, it's just obvious that you don't take the worst eye or the eye which is affected with microbial keratitis, but we would possibly look at the other eye to look at what exactly could be the clinical activity score. And also bring in the point that imaging has come up in a big way to correlate with what you're thinking is the activity. And that's helped a lot. I will touch upon a few other things related to the imaging a little bit later in the presentation. Just suffice to say that most of the times, situations like these that I showed, you have to jump in and take care in the form of aggressive surgery. And but also the fact that only decompression, as has been several times highlighted in the Western literature, to be honest, corneal breakdown as such is not talked about as much as DON in the literature or in thyroid eye disease. And it's important to remember that it's a combination of things that helps in managing corneal breakdown. You have to take care of the orbit with decompression. You have to take care of the eyelid, taking care of the retraction. You have to intensively treat with medical management. But the good thing is, or the silver lining is, you have a very good chance to have a good prognosis if you are aggressive enough. And sometimes, because they may be active patients, you have to also follow up them with immune modulation if that is the case. Quite often in our experience, we found that both corneal breakdown and DON go hand in hand. I'll jump into the next thing that I wanted to talk about, and I touched upon a little while earlier, and that was you will see increasingly that the significance of radiology and particularly MRI in getting a correlation of whether the disease is active or inactive. Quite often we come across this scenario where we're not very sure whether this is active disease. Should I treat? And we all know about clinical activity score and its fallacies, or also similarly the Visa I score. But the most commonly talked about these days is probably the signal intensity ratio. And all you're doing, like you like to coronal, which is outside the orbit, and the most common muscle that comes in coronal scans is actually the temporalis muscle. So that's what the signal intensity ratio brings about. But what it tells you is that how just inflamed it is, and sometimes also helps you manage the disease because you see the change in the signal intensity ratio. Not to be guided only with the signal intensity ratio. People like Susan Freitag have also talked about that it is also the T1 and the T2 relaxation times, if you can look at that, which are also seem to be corroborative with the activity. Taking this concept a little bit further, you can see this particular lady, a very large hypertropia, vertical strabismus, but you also see a correlating large inferior rectus. And just extrapolating from this information that we have about activity now, you could extrapolate in this lady who also had a large SRLPS, that now that you know that it is only related to one muscle group, you could possibly give a steroid right into the muscle, which is a lot talked about. And quite often these days, in the window period, I would think when you still can see active disease, again, active disease would mean with MRI, where you can show that the SRLPS has a high signal intensity ratio, you could give injections into the muscle, like in this case, and significantly make a change in the upper lid retraction. So that's what you understand from the radiology, bring it and could possibly make in the way you manage your patients. We've already seen this particular one from Namita, but essentially what it means is that you want to flatten out that curve and binding logics. But before that, we've already talked about immune modulation in the as a combination in the first line therapy, and in the era when we are struggling with our diabetes patients, we always wanted to bring in agents that were steroid sparing. And quite often we have used this, as in this particular lady, which almost for 1.5 years, multiple attacks of dysthyroid optic neuropathy, we managed with mycophenolate given for a long time. And whenever she had episodes of DON, goes without doubt, we treated with IV methylprednisolone for short courses. Eventually managing her with finally, for the decompression was done for the left eye. The scans tend to show that, and had a reasonably good follow-up, and she's happy. She didn't want any strabismus surgery for the small strabismus that she had. Then another patient where we presented with dysthyroid optic neuropathy again, managed with decompression done endonasally for the medial wall, followed up with mycophenolate for almost 5 months, and good results. The vision in the right eye did not improve completely because there had already been by some loss by the time the patient presented to us. So that's the reason it didn't improve all the way to 2020, but at least from where he came, he was much better that way and has remained like that. Also wanted to show his MRI images. And if you really closely see, you will see that tenting of the posterior pole of the eyeball, which tends to show that this is essentially a stretch kind of optic neuropathy. And the only way you can deal with them is actually surgery. There is no way any medical management would help. That's what is tending to show. Coming back to what we talked about on the Rundle's curve, if I put, rather sort of extrapolate the Rundle's curve onto a patient, this is how it would look. He comes like this. I treat him with IVMP or not treat him at all. But finally, he goes higher up on the curve, manages to reach a quiescent stage with large proptosis residual and eyelid retraction, needing multiple surgery to reach where we are. Now, if I were to change that, I would possibly need something that changes the disease course, which is what we're going to like to talk about on several occasions. Now, we've talked about essentially mycophenolate. We also talked about glucocorticoids, but as you can see, it essentially works on both T and B cells. But if you want to do a targeted therapy, you have to pick on one particular target in that inflammation cascade of the thyroid eye disease that we know and see. There are several. I don't want to touch upon many, but we talked so much about teprotumumab in the Western world and the changes it can bring in. We have tried our luck with tocilizumab, which is an anti-IL-6. And I would probably like to show some results. This was a young engineer presented in one of our secondary centers and actually came in very quickly within 1 or 2 months of the problem. He already had some early double vision when he came in. His MRI, I've already talked about the SI, the signal intensity ratios. Like I said, only 2 months, high CAS score, 4 out of 7. We put him on the standard IVMP. And soon enough, you see the CAS score just came a little bit down. But this guy is an engineer. He quickly told us, my double vision is getting worse. This is not helping me. A few cycles down, we realized this is not helping. We moved him to subcutaneous tocilizumab. What you see in the panel there with the month and the year tends to show what we got. The middle panel shows after about 4 to 5 months of tocilizumab, and that's the result we had. But interestingly, the last panel tells you that while the CAS score didn't come back, that means didn't get worse, the retraction did come back. So essentially, it means that we had a reasonable result as far as the inflammation, retraction initially, but he still ended up needing decompression and eyelid surgery, which you see in the last picture on the right bottom, and possibly may need further surgeries for the right eye eyelid too. But the good thing is the inflammation didn't come back, the double vision didn't come back. And that's what I want to say, that at least tocilizumab gave us a leeway, and that's where we are as far as this patient is concerned. We use tocilizumab as a subcutaneous, and when you do that, you essentially draw from literature of rheumatoid arthritis, where a lot of literature exists of subcute versus intravenous with similar results. There are other diseases too, as a very good safety margin. The benefit other one is you give 1/3 the dosage with subcutaneous tocilizumab compared to what you give with intravenous. Case 2, a patient, dysthyroid optic neuropathy, a smoker of 20 years, bilateral dysthyroid optic neuropathy. Now, this is where we thought we were going into difficult ground. We treated him with the first 3 grams, 1 gram each per day of IVMP, but then put him onto tocilizumab. And there you see dramatic results. The CAS score really settled down. But what we had here is something we had not had earlier, is a new onset esotropia. So something was happening there. But good thing was we finally managed to control the inflammation. Again, this particular individual didn't want any further surgery for the esotropia. He still has it. We're trying to counsel him for that. But good thing was he definitely had a control of the clinical activity score. Since we have talked about, look at on the right side, the pre-tocilizumab on the top panel and the post-tocilizumab MRI pictures. And you see the change in the signal intensity ratio. So we are very much on the right track. That's helped us sort of, reinforce our belief that this was helping. Case 3 is somebody who came with very high intraocular pressures in the range of 30s with 4 anti-glaucoma medications. Color desaturation was also there. CAS scores 4. And this is her when we started her with the tocilizumab. We had other options. She actually came in ready for surgery. We put her, and this is her after tocilizumab. The eyelid retraction remains the same, but 2 things had improved. 1, the CAS score had settled down. 2, the intraocular pressures were well within control now. So telling us that we had benefit coming from, but it is not that entirely the need for surgery had been obviated by using the biologic. And the last patient I wanted to share was this gentleman. The middle panel shows you after his IVMP standard UGOGO protocol, which didn't help at all. And he actually had a worsening. And then we put him on tocilizumab 2024, and the final picture almost gives him a year after. He definitely had settled down very well. So that's the experience I wanted to share about tocilizumab. If I were to present the same by putting it onto extrapolating onto Rundle's curve, this is how it would look. I would use the first patient. I used tocilizumab. He settled down. He came to a situation where his retraction had improved, CAS score settled down, but I still needed to do a decompression. So it's not that I didn't need to do a surgery, but I used an alternative drug other than corticosteroids and got a better response. That is a big plus. And the CAS score went down by only 3 points, which is quite good. Essentially, if I were to summarize, CAS score, clear benefit, inflammation settles down, and this could help definitely in patients, the risk factors we are talking about. But the other aspect is subcute seem to be working. We use subcutaneous 1 dose once every 2 weeks and 8 doses. That's a standard protocol we have, but you can escalate to once a week too, if you really need to. Other things, I think there on the extrapolation into eyelid retraction, double vision, proptosis, I think on the first 2, we had a little bit of a mixed response. On the proptosis, not much of a response. That's how it has been. We also had a couple of patients where it didn't respond at all. Last thing I would like to talk about is staged versus simultaneous surgery. Very quickly, we all know to take the picture on the left to the picture on the right, it takes years. And that's what's always a lot of patients want to know about, that I understand that this needs surgery and I have to wait for some time for surgery. But is it going to be taken several years before I'm okay to again go out and socialize? Another patient from the Northeast with a similar scenario, and the years are up there in very difficult COVID times when we had to manage. Essentially, final good result, but a staged procedure. But today, I think we can talk about is the situation like this. Again, bad disease, high intraocular pressure, and a combination of muscle surgery and orbital decompression done. And look at the result. The big other thing was the intraocular pressure settled down very, very well. It's to the extent that the intraocular pressure was so bad that actually the right eye had already undergone a trabecular glaucoma filtration surgery by the time he presented to us. So he's doing very well. Another patient, again, you can obviously take on with the eyelid and the orbital decompression together. So I think if I were to talk about, these are the things I touched upon. We have a situation where activity or the clinical activity score and a MRI multiple parameters, which seems to corroborate with the activity of the disease. Immune modulation has been talked about several times. Today, if somebody asks me, I would probably prefer azathioprine over mycophenolate, but that's for a different discussion. But biologics, in our experience, we seem to be getting somewhere with the sub-Q tocilizumab. And that's why we are just about beginning to do our prospective trial on moderate to severe disease in TED with tocilizumab. And finally, to probably shorten the duration of rehabilitative surgery, there's definitely a scope of simultaneous surgery. That's all I have. Thank you.
Thank you, Surya sir. Very well summarized and very interesting points you've put up. One question I have regarding the upper eyelid retraction. The steroid, is it only useful in the active stage or even when the fibrotic phase has set in? So is only steroid useful or any antifibrotic drugs for local injection can also be admixed?
Thanks, Ubaid, for asking that question, because this is, again, a very commonly discussed thing. I would put it this way that what is when we talk about, let's say we are extrapolating the imaging finding to trying to give a anti-inflammatory, let's say a deposteroid there. Till that much, there is a scientific plausibility, right? But I also am well aware of results or reports which tend to say that it also works in inactive patients where imaging has been done, not done. I would feel that probably in those situations, it doesn't make any scientific plausibility. You might as well get the same result if you put in a filler. But the point here is that I think the way to go is to definitely, if possible, look at significant retraction, consider doing an imaging so that you have a correlation with the inflammation, and then give an anti-inflammatory like a deposteroid within a period of 6 to 9 months. Even if it is later, it still makes sense to do an imaging and see whether you are getting the signs which are suggestive of activity from the MRI. The inactive ones, I would possibly not do a filler or anything else, or even corticosteroid. For inactive disease, I would probably resort upon doing a surgery.
Thank you, sir. Any other comments or questions?
Yeah. Hi, Dr. Surya. Very nice presentation. Have you seen any complications with the tocilizumab? Any complications?
I lost you for a while. Are you asking about complications for tocilizumab?
Tocilizumab. Yes.
Yeah. So you know what? Actually, I would think that the biggest advantage is that the safety margin for the drug for almost a decade and a half with rheumatoid arthritis is very encouraging. The worst complication that we have noted is one patient who developed a herpes zoster infection, and we had to defer a few, injections a few weeks. But if you look at the literature, the worst ones that are talked about is elevated enzymes, liver enzymes. You also have a little bit of a neutropenia and other things which have to be monitored. But other than that, there are no other major issues. You do have exclusions or contraindications of diverticulitis or probably patients with inflammatory bowel disease and all who are exclusions, which probably a physician or somebody could help you with. But with the drug, otherwise, no major issues.
Thank you. So will you advise any prophylactic vaccines before this? Because Kerala, no.
No vaccines. But in a scenario like India, any biologic for that matter, I came to know the usual thing is always screen for tuberculosis. And we would do that as a routine. Yeah.
Thank you.
Thank you, Surya sir. Very nice talk. So, sir, I want to ask for the one thing that for tocilizumab, like if we are giving starting the patient based on that MRI findings, that increased signal intensity ratio, not so. What is your like? How often you like want to repeat the MRI? Like after 3 dose? Yeah.
No. Yeah, thanks. Actually, you
Yeah.
know what? I would like to, but most of the times that's not something that I would rather do. I would still depend upon clinical activity score change that I keep as one of the major. You also have composite scores. So I would look at the same endpoints that we would look at the clinical activity score, the retraction, the deviation of the eyes, and the proptosis. This is pretty much what I would look at, right? I happen to have a few MRIs because, patients tend to shop around. They go around and they do a MRI and then come back. And it's only reinforcement that we also get the scan and we see we are pretty much in the right path. Yeah.
Actually, they ask you that कब करवाना है.
Yeah, exactly.
They are in more hurry than you actually.
Yes,
Yeah.
yes. That's
So
how I
with
have that scan. Yes.
yeah, the recent only that the another thing that I want to ask, sir, like as you said that with the proptosis you have a mixed response, but otherwise how much we expect ki proptosis should decrease with this
So I've lost you again.
how much the reduction of proptosis we expect with
So
yeah tocilizumab injection.
right. So again, I think if I get your question right, I'll quickly repeat that. What kind of a response is related to proptosis?
Yes,
Our
yes.
own response with proptosis has not been great, like I mentioned. A little bit with upper lid retraction and sometimes with double vision. But if you look at the literature report, I think we are talking about somewhere between 1 to 1.5 millimeters is what is talked about. It is not as dramatic, more than 2 millimeters, what they talk about with toprotumumab. So proptosis is not a great change with tocilizumab. Seems to be the general consensus. If you do you get a little reduction.
Yeah. Thank you, sir.
Yeah.
Thank you, Dr. Surya. And next, I would like to invite Dr. Marian Pauly for her talk. Please share your screen, ma'am. And she'll be
Hi.
talking on radiation therapy in thyroid eye disease.
Yeah, thank you. I hope my screens are visible.
Yeah, it's visible.
Yeah, thank you, Dr. Namita and the team of Charity Hospital for giving me this opportunity. I know after Dr. Surya's talk, he has covered everything in thyroid other than radiation. Okay, so so radiation, as we know, is
Can you
first
make it full screen,
Your
Dr. Marian?
presentation is not full screen.
full screen now. Full screen. Is it full screen now?
No, no. We can see your screen, but that is coming in not full screen.
Should I? Is the slides are moving now?
No,
No, ma'am.
your
The
screen is
presentation is not
visible.
open.
Yeah, presentation is not open.
1 second. Now, is it visible now?
Presentation is still not visible, but your window is visible.
Window is visible. Okay, then I think I will have some
I think
comments.
you need to reshare the
Yeah, I will
screen which has the presentation open.
Yes, I'll just give you one minute. Okay, actually, when I shared now.
So meanwhile, I can ask Dr. Surya that one question. Sir, do you use the MRI imaging to guide sometime for the decompression surgery? Because sometimes the patient with the timeline of 5 to 6 years comes to you in inactive phase with the proptosis, but they give that history that sometimes they have just the diurnal variation kind in the morning lead edema, sometime occasional. So that time, would you prefer also doing MRI just to see that is there any activity, residual activity?
Again, I think most of the time, Namita, what I would do is, if you're really talking about several years down the line, at that time, I
Yeah,
wouldn't
5 to 6 year down the
yeah,
line.
I wouldn't expect activity. They may say there is a little bit of a diurnal variation. I wouldn't. What I would really depend upon, I wouldn't get an MRI at that time. I would really depend upon definitely a CT to help me with understanding the kind of surgery planning for orbital disease. But what I would probably look at if I'm really in doubt is I could do two things. I could easily look at the patient's parameters, I mean, proptosis, retraction, and any of the others that we follow over a period of a few weeks, 4 weeks apart or 6 weeks apart. And are they changing? Okay, that's one thing which I could do to decide A versus do I operate or do I wait? Number one. Number two, if I'm really in doubt, I could actually give him a short course of oral steroids and see if any change is happening. Even a 7-10 day course sometimes tells you one way or the other. But generally, from experience, I can tell you that it very rarely tends to change anything. If they still tend to show as if they have some congestion, soft tissue signs, quite often these are congestive and they dramatically improve after surgery.
Okay, sir. Thank you.
I will just share once again because it is coming to this side, but
So, Marian, we can do one thing that you can send here. Should I start with the Mania presentation?
yeah, just start with the next, no problem. Now it is coming.
No, yeah,
Yes,
it's coming. It's coming.
It's coming. Oh,
Just
okay.
make it full screen. Yes.
Yeah, okay.
Yeah.
Thank you. Sorry for the delay. So radiotherapy, now it is full screen only, no?
It's visible. It's
Yeah.
visible.
Okay. So first introduced in 1936. Few indications. One is steroid responsive compressive optic neuropathy or as an alternative to acute phase decompression or prolonged steroids. So how it works? So initially I was also very skeptical about radiation in an inflammatory disease. So it actually modulates the inflammatory cells, especially lymphocytes, then activates HSPs, that is heat shock proteins, and induction of nitric oxide synthase in activated macrophages. Here in thyroid, what happens is higher doses are necessary to avoid synthesis of glycosaminoglycans by orbital fibroblast. This picture we have already seen from Dr. Surya. So what about the optimum dosage? Usually in my practice, 20 gray in 10 fractions can be either 2 weeks or 3 weeks. So in multiple studies also they suggest this as the optimum dosage. So the next question is whether it is radiation alone or with the steroids. So what we have seen is along with the steroids, it hastens the response. It exhibits a very faster response. And we have seen is improvement in diplopia at 4 months. There are various studies supporting this effect on muscles in combining radiation and steroids. Again, in compressive optic neuropathy, there are lots of studies combining orbital radiotherapy with the steroids in management of compressive optic neuropathy, where we can actually eliminate the acute phase decompression. So in our institute, we follow DAWN protocol. So what we do is when the patient presents with dysthyroid optic neuropathy, we give a loading dose of methylprednisolone 1 gram OD for 3 days, followed by methylprednisolone weekly 500, 6 pulse doses. So patient will be assessed every week, and at the end of 2 weeks, orbital radiation is added. That again depends on various other factors, especially if the patient is already having diabetic retinopathy, we prefer not to give. Then the pulse is continued and the immunosuppressant is added at 6 weeks, followed by along with oral steroids in a tapering doses. So this protocol we are following since almost 10 years and is working really well. So now what are the predictors of treatment response? We have seen Rundle's curve. So if you give the radiation within 12 months of disease onset, it is more effective and the steroids can be tapered off very fast, like in 2 to 3 months. But if you give radiation after 12 months, that is a little amount of fibrosis has set in, you might require more time. You have to give more steroids. So this also has been personally I have experienced, as well as it is literature also it has been reported. What's the optimum time to give radiation? It acts on the inflammatory phase, so give at the earliest. So now who all will not respond? So smokers, as we know, very bad prognosis in thyroid per se. Similarly, the duration of symptoms more than 18 months, I prefer not to give in radiation. Side effects per se very less. In the acute phase, you can have a little bit of dry eye, burning sensation, etc. Cataract, anyway, most of them will get because the patient is already on steroids, then age. Radiation can add on to it, but still that is quite acceptable to both the doctor as well as the patient. Then radiation retinopathy, radiation optic neuropathy is very rare. I have not seen secondary malignancies, even though reported for in literature, but I have not seen in the last 12 years of my radiation in thyroid practice. Come to the few cases. So this is 47-year-old gentleman, right eye treated euthyroid ophthalmopathy in the year 2014. At that time, he was treated with IVMB and azathioprine because at that time his thyroid levels were normal. So after 3 years, in November 2017, he presented with acute active thyroid eye disease with dysthyroid optic neuropathy. So we again started him on methylprednisolone. This was his Fields OCT, and we followed that Dawn protocol, Institute protocol, and this is at 2 years follow. So his activity has come down, vision improved, but the proptosis is remaining, no diplopia. And his forward force is remaining, but otherwise he is all right. Fields are also normal. And he is still under our follow, now completed almost 7 years now. So this is another case who presented to us with bilateral compressive optic neuropathy with active disease and lack of thermos. All both eyes movement restricted, right eye CF 2 meters, left eye CF 2 meters. Again, we followed a protocol that is IVMB loading dose followed by weekly pulse and radiation at 2 weeks and field effect. And at 4 months follow-up itself, he became inactive, even though he developed a mild squint and he did well. He had a small squint, but he was not bothered, even though he was a driver. So at 12 months, he is like more or less without any medicines other than topical lubricants, etc. So this is a very interesting case. He is 57 years when he presented to us, male, chronic smoker. He is not ready to stop also. He was treated for dysthyroid optic neuropathy in the left eye in the year 2019 with a 6/12 vision when he presented to us in 2025. So in the year 2025, he presented with acute active disease in the right eye with compressive optic neuropathy. So since he's a poor prognostic candidate in terms of thyroid eye disease, I advised radiation only along with IVMB. And after the radiation, he did well. He's under our follow-up. So this was his MRI. You can see the clear-cut difference between the muscle thickness in both eyes. Left eye treated in 2019, the right eye is currently active disease. And surprisingly, he became hyperthyroid now, but the left eye still it is inactive. So that's the one good thing about the radiation. Even if the thyroid goes abnormal, most of the time radiation has got a long-term effect on the eye disease. So now coming to my another patient. She is again active thyroid eye disease with the multiple risk factors. Diabetes. She had already received IVMB before presented to us. So she had steroid-induced fracture also. So again, infective keratitis with the right eye, hypopyon fungal corneal ulcer. She managed with compressive optic neuropathy both eyes. So initially we treated her with oral antifungals, covered the cornea with blepharotomy and tarsorrhaphy. Once the cornea settled, then she underwent decompression from the ENT surgeon. Post decompression, the vision has improved, the congestion, chemosis, everything has improved. While on improving, she developed drop in vision, so we did radiation also. Then she was under our follow-up, and by 2 to 3 months, she became inactive. Later, she developed cataract, for which she underwent cataract surgery. Then, after the cataract surgery, she had intractable diplopia due to the squint. She underwent squint surgery for that. So eventually, she did well with the right eye 6 by 7.5, left eye 6.6. And even though she became hyperthyroid later, like in the early 2025, her eye disease didn't flare up. That was a good thing which we have noticed in her. So her fields also, even the peripheral constriction were there, she maintained a good vision and good visual fields. So to conclude, what I have seen with the radiation, it is very safe and efficacious in attaining complete and persistent recovery. So this persistent recovery is very, very important in both moderate to severe disease as well as in sight-threatening disease, even with the corneal breakdown. Second thing, it modifies the active phase by decreasing the dependency on the steroids. Third thing, what I have seen in, like, it can replace acute phase decompression, especially when the patient is hyperthyroid, the risk for anesthesia, especially when you work in a single specialty setup. So it can replace acute phase decompression and related complications in a select set of patients. So these are my observations with radiation, and I acknowledge our radiation oncologist. I take this opportunity to invite all of you for the next annual conference of 2026 in April, and thank you so much. Thank you. In the OPI, there is a dedicated session for thyroid-related case discussions also. Thank you.
Thank you, Dr. Marian. Wonderful presentation. And there is one question from the audience.
Yeah.
About the route of the radiation. Is it EBRT, IMRT technique? And the dose, 20 gray over 12 fractions in alternate doses.
The dosage and the type of radiation, I usually leave it to the radiation oncologist. So I work in Central Kerala. In North Kerala, they give IMRT, even Central Kerala IMRT. The other part of the state, they give EBRT. So there is a difference between the side effects between these two. EBRT has got little more severe dry eye, like severe dry eye. They come with sometimes filaments. And especially if they have got an existing lag of ophthalmos, what I do is I always ask them to patch at night because otherwise it can have problems. So IMRT, it's very safe and very good. Dosage, again, I leave it to the radiation oncologist. Some of my patients, 20, some had undergone 21 point, again, 2 weeks, 3 weeks. Fraction is also, it's all, leave it to the radiation oncologist, their decision.
Okay. And since radiation therapy is very less frequently employed while managing thyroid eye disease, so would you like to, advocate for more frequent use of
even
radiation
in my
therapy?
practice, yeah, in my practice, my second line is radiation. What the argument is, thyroid is a self-limiting disease. So most of the time, if 2.5 years maximum, but some patients will run a very long course. And in few patients with systemic immunosuppression, I have seen some little complications, some little bit scary also. So thyroid has got only, radiation has only local effect, like it affects only on the eye, and no major complications like retinopathy I have never seen. Cataract anyway, it is treatable. Dry eye also it is treatable. So I advocate, actually I advocate radiotherapy as second line. after steroids.
Okay,
But
thank you.
only thing,
Any
counseling the
comments?
patient. Yeah, counseling the patient is very, very important because they have to go and sit along all these cancer patients. So it will be kind of little psychologically demoralizing, can be psychologically demoralizing for the patient. But when you tell them like this has got really local effect, no systemic side effects, we can reduce the dosage of steroids, etc., etc., most of the time they will agree.
Okay.
Open for discussion.
Thank you.
Yeah, a few comments, and I think very good results, very challenging cases, to be honest. Few comments is from the training I had with Peter Dolman, a lot of radiation back there. And I think over a period of time, one of the things I always felt was the challenge of treating diabetic patients, because that was unfortunately one of the relative contraindications. But over time, I've realized that you can really look out for whether you have diabetic retinopathy changes based on, again, fluorescein angiography and others, to really see which ones you can and you cannot. Number one. Number two, you can actually so essentially also have prolong the dosages to 10 fractions to much more over a prolonged period of time to help. But the key thing that I really wanted to ask was, I think the biggest advantage is radiation is one of the few which gives a big advantage as far as improvement in double vision. So if you are actually managing to treat early progressive disease, and the patient who has double in the extremes of gazes but not yet is double in the primary, that particular patient might end up having no double vision after surgery, after radiation, I mean. So that's a big advantage.
It totally agree.
Yeah.
Mainly the
Okay.
risk of
Thank you.
anesthesia and surgery. That's what I really like, moving towards RT in the acute phase. But
Yeah.
good anesthesia setup, good. And surgery is always good.
I think keeping in the time in the mind we have to. So I think that's very wonderful result, Dr. Marian. I think Anuruddh wanted to ask one question. I can repeat it. So one of our thyroid eye disease patient who has done and very habitual to that IBMP. So he got the sort of 3 dose of IBMP and then he lost. He has uncontrolled diabetes and not ready for surgery. For I mean to the decompression. Also has mild diabetic retinopathy because of the diabetes. Is it that patient is the right candidate for like radiotherapy?
We can give, actually, I advise, but always you can tell the radiation oncologist, don't give too much to the near the globe. Keep the radiation field little away.
Okay. Okay. Thank you.
So they can actually discuss with the radiation oncologist.
Next, we would like to invite Dr. Marnia for her presentation. She'll be presenting on thyroid eye disease, when to treat.
Mani, can you share your presentation?
Is my screen visible?
Yes.
Good evening, everyone. Today I'll be presenting thyroid eye disease, when to start. So as we know that there are various clinical manifestations of the thyroid eye disease, ranging from mild to moderate to severe thyroid eye disease, with 7 to 10% having sight-threatening thyroid eye disease, where there can be decrease of vision, decrease in colors, contrast sensitivity, there can be loss of visual field. So case number 1, 29-year-old female complaining of pain in both eye while moving for the past 3 months. Patient is a known case of hyperthyroidism on treatment, neomarcazole 10 mg per day for last 8 months. Patient is smoker for the past 5 years, 1 packet cigarette per day, and has a positive family history with both parents having thyroid disease. So on clinical examination, we showed that there was lid retraction in both the eyes with proptosis and restriction of the extraocular motility with diplopia in upgaze, and patient had an inflammatory score of just 1 out of 10, and other thyroid evaluation was within normal limit. So further TFT was done where it was within normal limit. Anti-TPO antibody was also within normal limit, whereas the TSH receptor antibody was raised. So diagnosis of moderate to severe thyroid eye disease was made according to the UGOGO. Further imaging was done where there was increase in signal intensity ratio in stir sequence, suggesting marked edema of the extraocular muscle in both right and left eye. So because there was increased edema in the extraocular muscle as well as diplopia, so patient was given intravenous methylprednisolone 0.5 milligram weekly pulse dose of total of 4 gram. So at the end of receiving the IBMP, patient showed significant improvement in the diplopia and the inflammatory score was 0. Now, case number 2 is of a 37-year-old male complaining of foreign body sensation more in the left eye as compared to the right eye and forward bulging of both eye for the past 1.5 years. Patient is also a known case of hyperthyroidism on treatment neomarcazole 10 milligram for the past 1 year. Patient is diabetic but non-smoker and no family history of thyroid disease. On examination, there was lid edema more in the left eye as compared to the right eye with lid retraction. Proptosis was more prominent in the right eye. Extraocular motility was restricted with diplopia in the upgaze. Here also the inflammatory score was 1 out of 10. So when patient came to us, the previous scan that was done 1 year ago showed thickening of the extraocular muscle with edema in the right eye. But when patient came to us, patient was symptomatic, more symptomatic in the left eye. We did the other thyroid, basic thyroid evaluation, which was within normal limit. TFT was within normal limit. So we made a diagnosis of moderate to severe thyroid eye disease. Further, we did the imaging where it showed increased signal intensity ratio in the stir sequence, suggesting marked extraocular muscle edema more in the left eye as compared to the right eye. So again, due to the marked edema of the extraocular muscles, patient received intravenous methylprednisolone, total of 3 grams, and then showed improvement in the diplopia and lid edema. So here is the prior to the IBMP, and here we can see there is reduction in the edema. And even in the extraocular motility, there was improvement where the elevation was restricted. Here we can see improvement after receiving the IBMP. So in both the cases, we saw that both the patient has very low inflammatory score and just diplopia. And only with the radiological evaluation, we could make out the activity of the thyroid eye disease. So I just wanted to ask the panel, what should be our approach for the silent presenter with a minimal inflammatory score? Thank you.
So this is something Dr. Surya touched upon. And
Yeah.
would you like to give local steroid instead of systemic in any of these cases?
Yeah, I think coming back to the question, I think it's very relevant for him with the kind of disease, and I think you did the right thing by imaging. The only difference I would probably, not really a difference, but I would, key thing that I would like to try to highlight is that if you're looking at, like, I think the second patient you were showing on the coronal scans, I remember in the left eye, both and the inferior rectors were. So it's I if giving a deposteroid, you may have to actually give it to two different muscles. or give it in a compartment where you would expect that it goes to both muscles in such a way. That's going to be a challenge. I think I would probably restrict myself to this particular cohort of silent predators, where I would probably use intraorbital steroid if the muscle enlargement is restricted to only one muscle. It's much easier that way. And having said that, I would also add that a lot of times after seeing this, unfortunately, in my own experience, I've not had a great response to any of the, either if I'm injecting the inferior rectus or the medial rectus, isolated muscle, intraorbital steroid, the response has not been good, not been very good. It has been a sort of a mixed, sometimes a little benefit where I'm not very sure. But for some reason, the response is far better if I'm looking at SRLPS as a complex. So how does that differentiate? Because I think when you're looking at a patient who don't have a very high inferior rectus or a medial rectus or both, and again a low CAS score, but both of them showing on MRI, are they different patterns of the disease? Are they same? Why do they differently respond to the same deposteroid? I really don't know. But I think these are things which seem to be which should be looked at, and then probably treatment paradigms should be titrated accordingly.
Yeah, one small comment from my side. See, what there is a category called superior rectus predominating TRO. It's like the previous studies, the standard teaching is inferior rectus is the predominant muscle involved in thyroid eye disease. But there is a new entity that I have come across is superior rectus predominating TRO. They respond well to local steroids. This is just my observation, which really we have to look into it. And most of them are like, there is a correlation between SR predominating TRO and TSS receptor antibody. So that we are yet to publish. We have looked into actually 100 patients, and like all those who are SR predominating, they are all TSS receptor antibody positive, and they behave little differently from the inferior rectus predominating TRO. I think we all can look into our data and analyze.
Yeah, that's an interesting observation,
Yeah.
and I think should be worth looking at.
Yes.
But I'm just trying to share my own personal experience with the difference that I see with the intraorbital steroid, the two groups. There was a question of the dosage when you were trying to Obed, it was a dosage about the intraorbital steroid. If it is, I think if you're, see, most of the time when you're trying to give an intraorbital steroid, you would go for a full 1 ml of 40 milligrams of Kenacort into the muscle because it's a bulky muscle. But I think from the literature and from our own experience, when you're talking about giving the injection into SRLPS complex, I would, both transcutaneous and transconj techniques have been described. I prefer using 20 milligrams, 0.5 ml of Kenacort above the tarsus by everting the upper eyelid. That's what I prefer doing.
Yeah. Thank you, Mania, for presentation. Wonderful presentation. Sir, I wanted to ask, such in this case, patient like this, both patients now they are not complaining of the diplopia and even not have any retrobulbar ache. So, how should like proceed further with such patients? Should we follow up just the disease activity with the clinical score? Yeah, imaging is useful in such patient in the follow-up.
I think the right thing to do is to just follow them up probably once a change at all, either in the retraction or the double vision, or for that matter, anything else. All along, it's equally important for us to tell them that you do not really want any sudden fluctuations in the thyroid hormone levels, because that could actually lead to a reactivation, at least a risk that way. So these are the things that you would look at. In case you face a change, that means either in the retraction or the double vision, proptosis, any of them, you would probably also look at, apart from looking at how the thyroid levels are, you would probably look at doing the TSH receptor antibodies again. But they're likely to stay the way, well corrected, and not having anything else. Quite, I think there's a very good. And if I recollect that one of those patients was very young, was probably young. I don't know what was the
Yeah, I think
age.
I
I don't
see around
recollect. One of those, that's probably a big, good thing for.
25 to 30, the first.
Yeah. So young TD is a good one. Is a good. It's probably a chance of reactivation. But if you have the same, you would see a patient who's presenting for the first time at 65, 70. Not only the slope of severity is very quick, but they tend to very quickly deteriorate and progress. But unfortunately, also they tend to show disease which is far more prolonged and needs much more, multiple modalities to bring it under control.
And for her, the profession of that she used to climb the rocks, mountaineer. So the thing is that diplopia in up gaze is very troublesome clinical features for her.
Yeah.
Yeah.
Yeah. Bad for her that way.
So, Ubaid, I think we can conclude that.
Yeah, so thank you everyone for your time. And all the talks were wonderful. We had a great discussion. And thank you everyone who's joined as attendees. Hope all of you could benefit from this. And see you soon, maybe in another webinar.
Yeah, this will be available on YouTube. Those who missed maybe can see. But at least I learned from this webinar and from Dr. Marian and Dr. Surya's talk. Thank you, Dr. Surya and Dr.
Yeah,
Marian.
some very interesting points.
Yeah. And thank you, Anurit and Ubaid, for
You
the
in Kochi also. See you in Kochi also.
Yes, we are
Thank
coming.
you.
Yeah.
Yes.
Look forward to that.
Yeah. All the best, Dr. Marian.
Thank you.
Okay. Thank you everyone and have a good night.
Thank you so much. Bye.
Good night. Thank you.
Good night.